So today's webinar is around the patient, the person, the individual, the customer. You choose, but it's all around the NHS 10 years plan and how we are going to make that a success between us. We're not expecting any interruptions, but if we do, apologies, but we've got contingencies. We have some great speakers with us today from both public and private industry, and I invite the opportunity for you to ask questions in the chat box or by raising the how hand for those that are old enough to remember how. And as we hear from the speakers, we'll try that opportune time to answer that question. Otherwise, we'll do it all towards the end. There will be a couple of polls, no other technology needed, just a case of putting your mouse in the option to choose. As I say, the recording will be available afterwards, as will the slides. But in terms of timings, as it's going to be very quiet times today, and I know we've got passionate speakers, I'm going to introduce you to our first speaker, Alison. And Alison, over to you to introduce yourself and your context, and I'll do the slides.
Okay, thank you very much. Can you hear me okay? I'm hoping you can. So
yeah, can hear you okay.
Afternoon, everyone. And it's good that we're recording this because we'll be able to share it to a wider audience. And thank you very much. I'm just going to set the session up a little bit. So we all know that the 10-year plan has been a really important, pivotal moment for the NHS. It's set a really clear direction for the NHS. And, I was listening to the news this morning. We've still got some major challenges in terms of our workforce, as well as serving the population and transforming all of our services. This isn't a new endeavour. All of us who've worked in the NHS and public services believe in continuous improvement and continuous transformation to meet the needs of the populations we serve, but also to meet the individuals that we serve through the services that we provide. And the 10-year plan reconfirms that direction, but really sharpens the emphasis on transformation to ensure that we have an NHS available to us in 10 years' time. We need to ensure that we are going to transform and seriously adopt new ways of working. And the three shifts that you will hopefully be aware of, that are very clearly articulated within the plan, are really about ensuring sustainability of the NHS, ensuring that it is orientated to meet the needs of populations, but actually that it's more sensitive to individuals' needs, and ensuring that it is modernised and available for individuals to be able to access at the right point when they need it at the right time in the right way. And it's sensitive to needs, sensitive to where you live, sensitive to your own particular needs and conditions. So the shifts that we've talked about in the plan is very much about moving to that more preventive early intervention model. Ensuring that we've got digital throughout all our services and that we are fully adopting digital solutions and enabling our clinical teams to be digitally enabled and supported, but also putting in the hands of patients digital tools and solutions that can enable them to take more control of their own care. And the NHS app is a perfect example of that, where you've got that NHS app and there's a lot of information and choices that are going to be wrapped around that. And ensuring that third shift, which is really about ensuring we've got that shift to community, to primary care and prevention. There's a big opportunity at the moment around neighbourhood teams and ensuring that our neighbourhood teams and places that we've got real exemplars about how those teams are going to be brought together and work together around the particular challenges in their communities, and the wraparound support, which includes financial support, workforce, digital tools, ensuring that we're actually got the right governance and arrangements to enable those to happen, to take place in the right way. So really looking forward to seeing how those new neighbourhood teams and new place-based teams work in the future in the context of the 10-year plan. And I think the binding bit between the individual and population, we talk a lot about population needs and a needs assessment. I've been a commissioner for many years, and there is a real emphasis on looking at the macro and looking at ensuring that we're allocating the resources in the right way, we're organising care in the right way, we're bringing in the right providers, working with the right NHS trusts and independent sector and third sector to deliver the sort of services that our population needs. And we measure the impact of that by looking at a whole set of measures that include social value measures, but also care delivery and population outcome measures. And we talk about the triple aim quite a bit in terms of that commissioning process, being clear about what dials do we need to move for our population, where are we falling short in terms of what we would want to see in terms of a particular community or a particular population need or specialty or condition. And what does that comprise of in terms of those particular impacts that we want to see? And therefore, how do we organise care and how do we organise services to make a difference to that? Now, the NHS is only part of the story, because in order for you to really make an impact on population outcomes and social value and the wider well-being of society, there is more than the NHS needed. And that's why partnerships across communities, partnerships across neighbourhoods and places are so important, because you're bringing to bear those wider public sector partners, whether they be leading from education, social care, industry, looking at the third sector, etc., coming together to really look at investing together to make a difference in those communities. I recently did a webinar on looking at social investment and looking at how you can galvanise the investment for communities to make a difference on what people really care about in their communities. So if, for example, the state of your local park is a really big issue for that community, then how do you convene and bring people together to look at that? So it's wider than just NHS service delivery, absolutely. And it's that wider partnership that makes a big difference. But I think the binding piece between population and individual is about standing back and looking at how are we investing all of our resources across the public sector and wider, and industry and employers. How are we working together to make a difference and move those dials, and stand back and say we've done a good job for our communities, for our population? But then how does that impact on you as an individual? That's really important to understand, because as an individual living within a family, living on your own, living in a community, what are your key issues that you want to see improved? And that is very much about your own local situation, really, and your local issues and your local personal issues that are really important to you. And we can connect those together very well through having a common lens of looking at what are the key priorities and how do we make a difference. So very interested in hearing today. I think we've got a dimension from the private sector, and very much interested in Beva and the work he's done to try and bring, if you like, individual focus in and measuring the individual's happiness, if you like, with the products or services that are being delivered. And then hearing from our professional team about how we go about taking our organisations and partnering our organisations through to ensure that we're taking an understanding about the health impact, inequalities impact, and also health needs. But the binding issue is a common understanding of what are we trying to impact, really. And I would say we can take heart from some fantastic work we continue to do across the NHS. And every day we're always celebrating, I hope, the amazing innovation and work that goes on in all of our teams. And here's an example that I'll just leave you with until I'm just going to hand over to the next speaker, which is an example on, what matters for you, which I haven't come across this before, but maybe Carla will put a little bit more in the chat about it. But it's actually the Scottish Government, looking at person-centred care and improvement. Published a little while ago there, but I think it's always a helpful note to look back as well as forward. So thank you very much. I'll hand over to the next speaker.
Great. Thanks for that, Alison. Good afternoon, everyone. Can everybody hear me clearly?
We're okay, thanks, Baba. Just to explain
All
very
right.
quickly, Baba's dialing in from a different part of our international world, so his camera may be off for the bandwidth, but he's absolutely here in passion and spirit.
Absolutely. Absolutely. Okay, great. So I'm Baba Opetu, Principal Managing Partner at Stragma. And yeah, excited to talk about patient centricity and the role it can play in terms of the future of the NHS and the 10-year plan. So roughly, I'm going to cover briefly just a little bit about Stragma and myself. But I'm going to talk about the centricity approach and the impact it has and can have, and the framework that we use to try to enable the thinking about centricity and to make sure that ultimately it's centered around the patient. And this need to change that we have, just to bring a bit of context in terms of change and why, even though it can feel a little bit unnecessary or like things are not changing, that actually change is something that we can react to and we can use as a positive opportunity. And I'll just close with some actions that we can take to increase our centricity approach. So Stragma's basically birthed out of 20-year plus of sales and marketing experience, and clients are typically in this sector, but maybe leaning usually on the private side with pharmaceutical, life sciences, and medical technology companies supporting them in terms of growth, marketing training, but as you can see, also specifically around patient centricity, which is the topic we'll be focusing on today. So maybe we start from the beginning in terms of what we mean, and just in terms of patient centricity, it's around the ability of people in an organization to understand situation, perceptions, and expectation. It's about just making sure the demands of the patient and the individual is the focal point of all decision, whether it's concerning the service, experiences, and really focused on creating satisfaction, loyalty, and advocacy. And it sounds obvious, but actually, as we walk through it, you see that actually it's one of those things that's common sense, but maybe not common in practice. I put this in because I thought it's also good to see it from a different angle. And this is Novo Nordisk, which is a sizable medtech company. And they say for them, patient centricity is not just a buzzword. At Novo Nordisk, they recognize that if they want to develop great treatments for patients living with chronic diseases, it's essential that they form meaningful partnership with their patients in order to bring this to play. And ultimately, whatever part of the ecosystem that we play in, we need everything to be centered around the patient. I think this illustration is really quite powerful. This is ultimately about a child who's dealing with and has diabetes. And what we can see here is that around this child, in order for things to work, there's a lot of stakeholders, a lot of interaction, pharmacy, clinic, hospital, doctors, but then there's a school, the parents, the home situation, and the wider macro environment. But ultimately, in order for us to provide the best services for this child with diabetes, we need to consider the context, the full ecosystem. And if pharmacy thinks within pharmacy or the clinic thinks within the clinic or the hospital, we miss the point. We miss what we're trying to do. And ultimately, what we're trying to do is to provide the best service for this child. And hence the title that the patient is queen, that it's everything works as long as we orientate it around the patient. So for customer centricity, we use a framework called the UCDI framework. And UCDI stands for understand, create, deliver, and then impact. And as we work the way through, it works clockwise. And really the understanding is understanding what's needed to delight this particular group of patient, this particular individual. What's their need? What can we do to improve? And what are the other stakeholders that are involved? Then in terms of creating, is that how do we create value? How do we improve the value that we create? Who can we collaborate with in order to enhance the value that we're delivering for this particular patient or groups of patients? And then about the delivery, it's really then thinking about who do we need to collaborate with in order to deliver? What resources are required in order for us to make enhancement to the delivery? And then just finally really understanding how will we make sure this approach is having the right impact in terms of service delivery, and how can we learn to optimize so that this becomes an iterative process and that we get better over time. And as we play forward, this really leads to a scenario where we develop an organization culture where we are obsessed about our patients, about our customers, about the individual that we're trying to serve. And then, so it really then we're talking about which patients, we're really focusing on the specific patient, their specific need and their specific context. We're thinking about their needs. What's holding them back? What's the pain? What's the gain? What are the things that we can do to help to alleviate some of the challenges? And then really about how do we create and deliver value for this patient collectively. And one of the most important thing about the patient-centric approach is that it's an organization that delivers it, not an individual. And that means that it's not just about front-facing staff or backroom staff. It's about the whole organization really thinking about the patient and then measuring our impact to ensure that we're having the relevant impact and we're improving the relevant key performance indicators. And as we see that, then this becomes an iterative process because as things are changing, technology, our environment, the patient, we're evolving with them. So in terms of change, I mean, change is this 10-year plan brings about another change for the NHS, but sometimes it can seem like nothing is really changing. And if you look at some of the facts here, this was 1981, a long time ago, when Prince Charles got married. Liverpool were crowned the champions of Europe. Australia lost the Ashes tournament, and unfortunately, the Pope died in 1981. But 2005 was also an interesting year because in that year, Prince Charles also got married. Again, Liverpool were crowned champions of Europe. Australia lost the Ashes tournament, and unfortunately, the Pope died, a different Pope. And the key thing is, I think, well, what's the lesson learned there? What can we take away from this? And when I reflect, I think that maybe the next time Prince Charles gets married, somebody should warn the Pope. But in effect, I mean, it can appear, if we look at certain statistics and point, as if nothing is changing around the environment. I hope there's not much persuasion to see that there are a lot of changes. We're all familiar with this quote from Charles Darwin, which is really interesting, that about emphasizing the point that it's not about the strongest species that survive, nor the most intelligent, but actually the ones most responsive to change. Patient centricity is about our ability to respond, our desire to respond, and our determination to continue to evolve. And this time we're evolving and responding around our patients. So I have a picture up here at the moment, and just for a minute, I'd like you to just reflect on this and have a look at this picture, and maybe a few people can, put in the chat, what do you think is going on there? What's the explanation for what we're seeing in this picture? Any thoughts around what we think we might be seeing? If I get one attempt, I'll give the.
There's a flying rock.
A flying rock, yes, it looks like a flying rock for me. I think that that's credible to say that it looks like a flying rock or dropping rock. But if we just play this forward to the next slide, and what we see is that actually, when we look at it from this point of view, there was nothing spectacular or particularly complicated about this picture. it was just upside down. And when we look at it upside down, it becomes very difficult to either understand it or to come to conclusion. And so sometimes it's also important that we are looking at the scenario in the right way. And so what does this have to do with patient centricity? What we're saying is that when we look at it from the patient's point of view, we see things differently. We get a better understanding, we get a better insight. And so this quote by Marcel Proust is one I like. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes. And the new eyes we're talking about here is really the eyes for the patient. The eyes that means that we take advantage of this 10-year NHS plan by making sure that we drive it through a patient-centric lens. So in terms of patient centricity, this is an example of the kind of offering or program that we use to help organizations to walk through to maximize the ability of different parts of the organization to focus on the patient. So usually going through preparation and setup, we use surveys, we do voice of customers to get insight, we run workshops to make sure that people get deep understanding around how to take advantage of this, and sometimes mastermind sessions to get underneath some of the bottlenecks that's holding us back. And then, we deploy tools like, short videos, another element, all along the way, making sure that we move and we help the organization to arrive at a point where they have a playbook of how to deploy patient centricity in a way that helps with their plans. And ultimately, this approach does mean that it allows us to adapt to digitalization, allows us to be effective in terms of retention, acquisition, and ultimately it means that we drive results on the back of this, and we become much more we have a greater sense of purpose around what we're doing and what we're trying to do. And of course, the NHS is a part of industry which has this naturally, but this is an additive to it. It means that we get results and actions are all focused around the patient. So as an example of sessions that we've run, and you just look at the feedback here, how confident are you that your organization will make significant positive change in the level of customer centricity over the next 12 months? You can see there the extremely confident was the highest score. Again, how convinced are you that this will increase and lead to improvement in overall performance? And again here, and then if we play further, we can see that this particular organization in this case study, that they won awards. I'm just waiting for so they were able to win awards on the back of the performance of the change. And this was a program that lasted, in this case, it was quite a large program, 15 months. I think the important thing is that you can see from some of the pictures on the right, we worked right across the organization. So this is really about bringing everyone together to focus on the patient and to take a different reflection on how we do. Now, I know that naturally we are patient focused and organizations are customer focused, but this is really about being patient centric. So really driving the focus and the energy much more around the patient. Great. Okay, then I think that was the last slide for me. Really saying that this is a program that I've seen work very well in many arenas, and certainly within the healthcare sectors with some of the private providers. I'll pause there and I'll hand over to Dr. Lyons.
Hi there. So my name is Cathy Lyons and I'm from Solutions for Public Health, which is a lovely small public health team which is based within the NHS. And we've been going for somewhere in the region of 25 to 30 years under different guises, and we do a lot of project work. A lot of it's evidence-based work, so a lot of evidence reviews for specialised services for the UK National Screening Committee, but we also do a lot of health needs assessments. And our health needs assessment role is focused mostly on local authorities, but we do health needs assessments within the NHS. And obviously, when we do a local authority health needs assessment, it encompasses the NHS role within those health needs. So it's what we're doing is we're pulling together an awful lot of information. So the patient voice is incredibly important in health needs assessment. But as we're within the public sector, we also have to take account of resources. We've got limited resources, so we need to think about that. We need to look at evidence about what works and what doesn't work. So we have to balance all of these things. And what we're aiming to do is to improve the health and well-being of everyone whilst reducing inequalities, improving the quality of the services and the use and sustainable and efficient use of resources. So we look at the triple aim and we bring that into the way we do the health needs assessment. This is our approach to H&As. So what you see on the screen here is our, what you might call our all singing, all dancing H&A. So we will include interviews, semi-structured interviews with questions for commissioners of services, providers, service users and the representatives. Usually with the service users, they might be peer mentors, they might be patient advocates that belong to a patient advocate group. Occasionally they are just service users who are well known and happy to talk to us, but we don't usually go back cold to people for interviews. We will often have a workshop then pulling together the information, the themes from the interviews, and then we might do a really broad survey. So we've got kind of key themes because the surveys go wide and the interviews and the workshops go deep in terms of picking up qualitative information. And the qualitative information we're looking at is a lot around what patient service users know about services, experience about services and what they want from services. And it's trying to reach everyone that you can so that you could draw those themes, and you'll find that there are very common themes that come through often. If we can't get hold of service users, in some areas it can be really difficult to do that. So we usually go for people who are working on the front line with those patients and have a really good, often people who are working on the front line have a really good advocacy role for their group, the people that they work with. So obviously we need to look at data as well. We can't just talk to everybody and say, what would you like? We look at the data, we look at what we've got in our community, who have we got in our community, what do they use in our community in terms of services, you know, whether it's a smoking cessation service or if it's a weight loss service or drug and alcohol misuse services or any of the NHS services as well. So we're pulling data from services, we're pulling data from the population in terms of who they are, where they live, all the demographics, and also the KPI, so the key performance indicators of those providers and what they're doing currently doing for people. So those quantitative findings all go into one section next to the qualitative findings, and then on top of that we have best practice and evidence. And so the best practice and evidence becomes the framework that we synthesize the data and the qualitative work around. And when we've synthesized that, so under the framework of evidence and best practice, under that we want to come to something that looks like a person who has their own story. They understand what their needs and aspirations are. They have networks around them. They have safe places they can go in the community. They have places they can go for healthcare or other kind of community support. They have people around them who they feel connected with and peers. So what we're trying to build when we're looking at local authority and NHS services and the third sector We're trying to build this network, and if you think about the individual, that's what we're trying to do, is the individual and their community, and make that a safe place where their needs are met. So this is the aim. This comes from a service specification that Plymouth City Council produced when they were asking for people to bid for services for people with complex needs. And this image, and I know it sounds a bit bizarre, but I think everybody has complex needs. We are all quite different, but we are all the same at the same time. And we have to really feed into what is the most important thing rather than just looking at evidence and data. Next slide, please. Thanks. So I know this is a lot of words, but this gives you, these are my 3 examples that I have at the moment for where can I show that this works. So the first example from one of our NHA topics that we were doing last year was looking at smoking tobacco control. So we were doing this in an area where actually there isn't a huge level of smoking. Smoking isn't that high in this area. And there were NHS initiatives within the Acute Mental Health Trust for people that were sectioned, were on the ward, so they weren't allowed to smoke, but they could vape. As soon as they were discharged, the community provider picked that up, but actually the community provider couldn't support people in the way that they needed to be able to carry on starting to quit smoking by shifting to vapes and then coming off nicotine. And that wasn't the community provider's fault. They were actually ticking all of their KPIs, lovely, wonderful. It was all doing, a wonderful job, but they didn't have the flexibility within their service specification at all to be able to offer an agile, targeted approach for this group of people. And so what you're looking at isn't that, there's anybody doing anything wrong particularly. It's just that when you're setting up a service specification, you need something which is more flexible and isn't quite so tight, because you don't have that agility when you come across groups of people that need things to work in slightly different ways. That isn't there because the budget is very fixed around particular KPIs and particular activities. So what we're trying to do is make resources, rather than generic, it's much more targeted, especially if you've got a general population that isn't smoking much. You need to be looking at those targeted populations. And what you're trying to build with this is a relationship. You're building a relationship between the acute mental health wards and the project officers there that are working there, and the community provider and the patient, and you're trying to build relationships across that place so that people are supported and their needs are met throughout those settings. Second example is the specialised services, so completely from prevention to specialised services. Now, people with thalassemia, they experience intersectionality, multiple inequities, because they belong to marginalised groups. Thalassemia happens to people, it's a genetic illness condition for people that come from or have an ethnic heritage in malarial areas, because it was a kind of mutation which helped people stop having malaria. But if they had the full mutation, they were likely to die before they were age 5. And so they're likely to live in areas of deprivation. They're likely to find it difficult to navigate employment and studying with this condition because they need blood transfusions every 3 weeks. So they have multiple issues, and multiple issues just getting to the hospital, just getting to where they need to be treated. And so what we recommended was there was a key worker based in each specialist NHS team who works with the relevant authorities, the other NHS services, and the patient to help them not only access information and services, but also to support them to understand about their condition. To work with employers so employers understand what people need, because often employers don't like it if they've got people who've got long-term conditions. Help with how to get into studying better in ways that work, that are flexible. And this will help also people be compliant with their medication, which is really not particularly pleasant. So all of this will improve the outcomes. It will reduce the costs of comorbidities and people having longer stays in hospital for when things start unravelling and going wrong. It will improve their capability to be productive in the community and feel meaning. And so you're building, again, relationship between the patient, specialised services, other NHS, social care, schools and employers. And all of that helps people get to where they really want to be, and helps us in terms of reducing resource use. And the last example is around a sexual health needs assessment we did, and we found that, and it's common across the country, that women, there is not one place they go for their cervical screen, their contraception, their pregnancy advice, their sexual health advice, or anything to do with their sexual health. They're going to multiple places all over the place, and sometimes they can't access, for example, contraception. Sometimes they can't access having a cervical screen in one place, which happens to be their GP practice. So there's a recommendation which is actually based on NHS policy, which has come out, which is to have a women's hub, where you have all the funding that goes into all those multiple contracts pulled together, so women have one place to go to do all of these things. So if they've got a menopausal problem, if they've got a menstrual problem, if they've got anything around pregnancy issues, they can go to one place. They know where they're going, and it allows savings from prevention of all the issues that happen because people aren't accessing the right place at the right time. So again, we're building relationship between women and dedicated holistic services. And the whole point of all of these things, when we're talking about talking to patients, finding out what works and what doesn't work and what goes wrong and where things fall apart, it's all to do with relationship. It's the falling between two stools. It's the who's talking to who likes and enjoys being with who has a problem with it. And so this last side is really what I would recommend to anybody who wants to think about why we are doing this. And it's because if you put something in place, it will only work if you have considered all the relationships that are involved, and that means talking to everybody and making sure that you're meeting their needs, because without understanding the relationships of the people involved, you're just going to get some conflict on your hands. So that's what I would recommend to anybody before you kind of design your own plan of action for something. Just talk to everybody. I mean, I think it is common sense, but it's also really difficult to do, and it's really more expensive to do up front, and it's just harder. It's a lot easier to look at some papers and to read the data, but we really need to talk to people. Thank you. Thanks very much. I'm going to hand over now to Mojisola, and enjoy the rest of your talks.
Hello, everybody. Thank you. That was a really helpful understanding of health needs assessments. And I think some of the themes that have come from Baba and Catherine, you'll be able to recognise again as we look at equality impact assessments and the role that they play in terms of centricity. We're going to spend a little bit of time just looking at what is an EIA. We've got a scenario for you. My colleague Jamila is going to be joining me to take us through a scenario for us to all have a go at looking at some of the impacts and mitigations that we might identify, and also the positives that we can learn when we go through an EIA process. And then, you know, open it to you if you've got any particular questions around EIAs. Now then, just to add a little bit of context, what's the difference between health needs assessments versus EIAs? So equality impact assessments focus on assessing the potential impact of policies, decisions and practices on different groups with protected characteristics under equality legislation, ensuring fairness and preventing discrimination. HNAs, on the other hand, are broader assessments of health needs of a specific population, aiming to improve health outcomes and guide resource allocation. And what we would say is that HNAs are very much part of that information gathering that you would be doing as part of any equality impact assessment, and that they would really speak to EIAs if they are available. So what's the importance of EIAs to the 3 shifts? As we all know, the 10-year plan is outlining these shifts from analog to digital, from hospital to community, and from treating sickness to preventing health. And as we move to embrace and implement programs to deliver against these 3 shifts, we should most definitely be completing robust, well-considered EIAs. This is going to help us identify positive impacts and opportunities, identify negative impacts and opportunity mitigations. It's going to help us to establish proportionality. Where will there be the most impact in terms of access, experience and outcomes? Where can we give priority to those positive impacts and mitigations as we're going through any decision-making process? And importantly, as I've said, the EIAs will align and do align with health equity assessment methodologies. So HEAT, some of you may be familiar with, helping us to understand if there are any health inequality issues and looking at ways of developing programs and systems to minimise those inequalities. And then, as we've said, the health needs assessment. So I'm going to hand over to my colleague Jamila, and we're going to take you through a scenario which I hope you will all join in with.
Thanks, Moji. Right, so if we go straight into the scenario then, if you have in front of you a GP practice that's being decommissioned, but now you're involved in the commissioning of a new GP practice, you want to look at a GP practice that's located in the 3rd most deprived decile, which is IMD3. And it has a patient list size of 10,000. Okay. Now, because we don't have time really to look at all 9 protected characteristics, in this scenario, we're just going to look at the protected characteristic of race. So what we're going to ask you is, what we need to do is to understand the impact of this change, decommissioning one GP practice and putting another GP practice in its place. What's the impact of this change on the protected characteristic of race? Okay, so if you can please consider the following question. Well, we've got a couple of questions. The first one is, what are the positive impacts and opportunities for this change? And it's really looking at the lens through race.
Thanks, Jamila. And just for the audience, I've opened up the poll just to promote that conversation a little bit in terms of, what do you feel as a patient, as a person, as an individual, as a commissioner, someone who works in the NHS, what do you feel are the positive impacts here on the opportunity of the change of that decommission of the GP surgery? So some of those results, Jamila, if you want to pick up the conversations, patient care, right in the centre, that's good to see. Commissioning needs, flexibility of provision, access, design.
Yep. And, just to reiterate what the previous speakers said as well, perspectives do matter. And it's really important that you do listen and hear from people in the various different communities within that location, and understand what the potential issues might be for them. So the positive impact then, we're looking at access as a positive, an opportunity to redesign. So yes, you can actually go out there, do your research, speak to people, speak to your communities, and redesign that service to best suit them. Be flexible in your provision. It's, you can't have a robust plan that you're never going to change. It's got to be flexible. opportunity, yep. Commissioning. And love those responses. Moji, did you want to come in and say anything else on that one?
Well, I'm just thinking about how that sort of ties in and now to think about the negative impacts and mitigations, and then we can draw together some of our thinking, can't we?
Yeah, yeah. So the next question that's out on the poll now is, what are the negative impacts and the mitigations linked to them that you might consider going forward with this change? So again, negative impact to patients. What would those negative impacts look like to patients with the lens of race?
So we've got continuity in there. Yeah, continuity of care, I guess, for that same person.
Yeah.
Defranchising
part of, yeah. Defranchising part of the population.
Costs, important, very important. Reduced access, potentially.
Would anybody like to come in and join the conversation on either the negative or the positives here of doing a quality impact assessment based on the conversations and the discussions we've had so far in terms of that patient lens or the patient centricity from a health needs assessment? Please just raise a hand or put something in the chat box. Otherwise, yeah, you continue, Mojisala, Jamila. It's great.
Yes, so if we have a look now at the types of things that Jamila and I have identified in terms of the positives and the negatives, that might be useful.
Sorry, I'll just get rid of that box. Yeah, so in terms of positive impacts, yes, we can tailor our services for the population in that area after we've spoken to them. We can have a well-informed service with co-design, and that benefits everyone in the population, not just that one population that you're looking at. We could be reducing barriers to access, whether that's physical, cultural, or systemic. We'll be identifying training requirements for workforce as well as, thinking about patients. It's really important to think about workforce. We could be, when you think about benefits for one community, it often improves the access or the service to the rest of the communities as well. Okay, and Moji's got a lovely little anecdote for that one, haven't you, Moji?
Yeah, so I always like to use the analogy of a rising tide raises all ships. So we might be focusing on one area, however, that impact is going to be something and benefit for all of us once delivered.
Yeah, and then in terms of the business case, all of this can evidence your add to the evidence in your business case. So you're making a more robust business case for your change as well. Okay, and then in terms of opportunities, we're looking at positive inclusion. We're looking at building relationships with our local communities. Looking at the greater understanding of the local area. So as soon as you start thinking about a change that you're going to be making, you already have a greater understanding about who you're going to be serving. But when you do your equality impact assessment, it helps you to focus on each of those protected characteristics. Creating services co-designed with the community for their diverse needs with those in mind. And then it's a global reach, benefiting the whole population and not just, as we're saying, just the one community. And then, of course, evidence in the business case helps you to gain funding for the project itself. Yeah. In terms of the negative impacts, then, There could be barriers to access for those people outside of the area and potential for transport issues. So it's really important to identify those and bring them to the point of having mitigations or considering mitigations. So for that one, you might want to think about good transport links. You might have underrepresentation across the demographics, but you want to make sure that you have a robust engagement plan for representation across the demographics. And I know it's not an easy thing to do. It does take time to build those relationships with communities, but once you start and they see that there's something in it for them because their services are better to access, the better services appropriate to them, you'll get more traction as well. Okay. A lack of cultural awareness within the workforce, and what you can do for that is training and raising awareness and having those conversations to encourage people to communicate with each other better. You might have language barriers, and in that case you might want to think about accessible information and making sure the accessible information standard is applied. You might want to go down the lines of looking for interpretation services. Okay. If there's a discontinuation of the previous trusted relationship, how's that going to affect your community? You know, you get some, you know, the old-fashioned single-handed GPs. People had a connection with their GP. How do you deal with that? You've got to have a robust communication plan and an information plan and guidance to make sure that your communities are on board and engaged with the whole process. Okay. And then if you've got issues with service continuity, you might think about what's your contingency plan for continuity of care going forward. And that's again something that was picked up on the poll that we had earlier on.
Thank you, Jamila.
Thanks, Moji.
So that's given us a bit of a snapshot, but if I go to the next slide, please, Carla, just to really conclude our section on this. You know, quality impact assessments, they're tools, they're there to help you, they're there at the very start of your planning cycle. And look, we've got this commissioning cycle here, and we would urge you to think of EIAs as part of that. I'm not going to go right through the circle, but really at the essence, it's about gathering information, using things like your HNAs, your heat tools to understand your populations. It's about engaging and consulting. It is around legal compliance. We all of us have to demonstrate the public sector equality duty is being met. EIAs will help you to do that, as well as that moral thing. You're going to be meeting your people, your centricity. And finally, it's at the heart of continuous improvement. If that's your approach to any decision making, EIAs are certainly part of that continuous assessment, continuous improvement. Thank you, everybody.
Thank you, Moji, Sala, Jamila, Kathy and Baba and Alison. That's in reverse order. So we've got about 4 minutes left before we need to end this webinar and this discussion. But is there anybody that would like to ask any questions whatsoever? And I've just put a few sort of thought-provoking questions there in terms of what are your next steps in making sure this centricity is absolutely key to you, to your commissioning, to your service, to your neighbourhood, and how it really does matter to that individual. I'm happy to stop the recording at this point because I know absolutely we've had a lot of conversation, a lot of thought provoking, but we also welcome here, but before I do sort of ask Alison if you wouldn't mind to do a very quick summary and closure. If anybody feels that a one-to-one discussion would help them, then please just reach out to us. We will send out the slides and the recording, but the one-to-one discussion might just help you to understand how this can be implemented more effectively into your work, into your system or your population. It can be very complex, as I think the message has been portrayed. But here are a few questions. No
Thank
questions
you.
from anybody else. Alison, over to you. Thank you.
No, I was just waiting to see if there was any hands or
Mm.
contributions, but that's just been a really good session. So thank you very much for colleagues, and Babo, Kathy, Jamila, Moji, thank you so much for your time in terms of, you know, what you've managed to portray has been excellent. And I think we've sort of anchored it very much in these last few slides around the triple aim, the importance of thinking about populations, and importantly, thinking about the intended impact and the potential unintended impacts we might have on populations and groups. Baba talked very much about the value, different language, but the same. You know, what's the value? What's the value we can add? What's the impact in terms of measuring that value? And then he talked very much about pain points. Kathy talked about my story and talked about health. So there's a language here that may be different, but actually it's all the same, really, in terms of what we're intending to portray, whether you're taking it from a commercial customer organization-centric approach, or whether you're looking at it from a population and what impact we make on individuals in our populations. It's the same approach. And I'll just leave you with this thought. Well, I think one of the things that came through to me with all of this was we've got these tools that we can use, and we can use them in a purposeful way. We can use them in a very sort of formal way at formal points around a commissioning process. We've talked about health needs assessment, equality impact assessment. We've talked about that cycle of commissioning. But what I'll leave you with is the thought about the culture and the relationships and seeing things differently that Baba talked about. How do you build that different culture which empowers teams to really think that they are able to make these changes in services? Some of them can be small changes that will have a huge impact. And so building that culture, which is built on really strong relationships between teams and community partners, is the critical thought I'd leave you with, really, because I think that is going to be even more impactful than some of the big things we do as the commissioning support organisations around the NHS. So thank you again, everyone, and we will circulate the slides and the recording. Thank you very much, and thanks, Carla.
You're welcome. And if anybody would like to schedule a call, then I'm happy to stay on the line to do that with your diary while it's open. Otherwise, thank you to yourself, Baba, calling in from your wonderful place in the world. Alison, thank you, and Kathy, Moji, and Jamila, thanks for your time. More importantly, but equally, thank you to the audience for taking the time out to reflect on patient, person, individual, but centricity in your community and neighbourhood. Thank you.